And the outcomes have shown that even digital only can save significant dollars. It can improve employee productivity. It can reduce missed time from work, which those things a lot of times can go hand in hand. So we see benefits with them. As you already alluded to, one of the biggest problems is the utilization rate is around 2%.
So how are you?
I'm doing great, Rafi. How are you?
I'm doing all right. I'm looking forward to diving into the topic of content, knowledge translation, and all that. But before we do that, why don't you tell us a little bit about yourself, your background, and what brought you to what you're doing now at Second Door Health?
Yeah, sure. So my name's Zach Wilson. I'm a physical therapist. I've been for about the past 10 years now. I started largely in private practice outpatient, worked for a practice called PT Solutions. So I did my residency program, moved up the ranks there, then got a lot into education research and running their residency program for about 6 years, involved with it pretty much the whole time I was there. But then recently, in January of 24, made a switch to a company called Second Door Health. So I've been advising for them for a couple of years as a new startup and realized it was a good fit for me to move on to them. It is, like I said, a startup where I'm their head of clinical there right now, and we're really focused on the direct care market, specifically looking at direct to employer, which is something we can talk a little bit more about, but I handle all of their quality aspect, their clinical content, and we'll be getting into the research part of things and outcomes as we continue to expand and work with more clients.
Yeah, that's interesting. So I guess tell me a little bit about that transition, because were you treating patients day to day at PT Solutions, or were you more managing kind of the quality and that fellowship program and all that?
Yeah, not day to day. My main work in the clinic was as a mentor with residents. Okay. And so I would mentor 1 to 2 different residents during the year. It was an 11-month program. So I'd be in the clinic every week, but I would usually be helping oversee and coach on treatment. I myself would treat occasional patients, whether it was take someone over to help or to fill in if somebody was out. And sometimes I'd have old patients reach out to me, but it wasn't any kind of regularity that I was carrying a schedule.
Yeah. So I guess the transition then from that to what you're doing now, not a whole lot has changed other than you're not in the clinic as much.
Yeah, now it's completely remote, so there's not the 1 to 2 weeks in the clinic. And then probably the biggest difference was also Tuesdays where I'm not teaching residency. So I used to do a lot of prep for that and teaching the 60 some odd residents we'd have in a class. So that was a difference in going from a company where I would work with 1,500 people to a company now of 6. So that's a little bit of a change in getting used to, but it's been really good.
Yeah. The startup world is a little different than clinical.
Very much so. Very different.
So I'm curious about this whole direct payer employer market deal. So I'm assuming you're going like directly to like a big company, a big employer, maybe Bridgestone, Georgia Pacific, something like that. And you're saying, listen, like what's the value proposition that you're offering in that scenario? And then how is like Second Door kind of helping clinicians with that?
Yeah, sure. So big picture, like direct care, it's going directly to that payer. So instead of having Blue Cross Blue Shield or Aetna, however you're using, you would go directly to whoever the consumer might be. Now, a lot of times when we think of direct pay, we think of cash pay.
Yeah,
but
like
cash pay does, right. But that does have its limitations, right? It's hard to scale, the socioeconomics of it for some individuals. It's just not something that they can afford to do. And if they also have insurance, it's kind of like, well, I want to be able to use that as well. And so
might as well.
Yeah, exactly. So there's those challenges. Not to say cash pay can't work in many situations. Where direct to employer works is that instead of having the insurance or the individual pay cash, it's the employer that's paying for those services. And the benefit to the employer is that it's typically very cost effective. And so you're seeing more. It's something about 65% of the U.S. workforce now works for a company that is self-insured. So they'll use Blue Cross as like a third-party administrator. It's a wrapper, but really, even though your card says Blue Cross Aetna on it, the company itself is who's paying all those claims. They're the ones who are pulling all that money and really the ones that are taking the risk. but that means that they get the benefit of it, because if they keep their workforce healthy, they have fewer health claims to pay, and they reap the benefit rather than an insurance company reaping the benefit. So really where we come into play here, saying, hey, one of the best ways to save MSK costs is physical therapy.
Yeah.
And especially doing physical therapy early and having easy access to it. And so we're a software company that positions and helps, the easiest way to put it, we help outpatient physical therapy practices find and service those contracts. And so we give them the whole tech stack that they would need to go to a company, whether it be a small regional company of 200 employees, or depending on what you can service, a really large one, like I'm in Atlanta. So if we could go, hey, Home Depot, we'll take care of all your MSK issues, and here's our network of people that can service it, and that's an approach. And direct to employer is not something that's necessarily new. It's been talked about growing more traction lately, but it's something that can really help people save costs and take out the unnecessary system that a lot of patients have to navigate through, where they can just go directly to the physical therapist to get better.
Yeah. And I'm assuming a lot of that involves you're obviously with that model, you're stepping totally out of this fee for service. You're not billing per unit. A lot of times it's usually either set up per employee or per case incident, right? The dynamic of the reimbursement changes as well too, which means that the clinician could potentially treat at higher margins, right?
Yes, so the margin's typically higher. It can be those ways, and it can still be a fee for service. You just typically don't see the unit charge.
Yeah.
So typically what you'll see is either a fee for service visit, where it's just, hey, every encounter, and oftentimes that charge is going to be in between where you might see a payer and cash pay. You're going to see case rates where it's like, hey, this is what I treat for acute low back pain or so forth. And sometimes you'll see subscriber rates where it's, hey, for every one of your employees, it's $2 per employee per month or something like that. But then they get unlimited services. So you might only have 5 or 10% of your workforce that actually uses it, but it's still a win-win on both sides. So there's a lot of different ways that it's structured. But that is the beauty of it, is you can structure it the way that is best for the employer. And you can even include wellness programs or other things in there. There's a lot more flexibility.
Yeah. Tell me a little bit, since you're the research guy, tell me a little bit about some of the outcomes for these programs. Because I know without naming any huge names, there are some tech companies that have got into the space and they were doing virtual first, and it was a big push. They got a lot of PR, a lot of funding, but then their utilization was really low, and now they're looking at maybe opening up brick and mortar clinics and all of has there been a real value to the employers with this type of approach, or is it one of those theoretical things that the healthcare industry is still trying to figure out, how do we offer these services in a way that's going to be beneficial for employers and for patients in the long run? Yeah,
so you bring up a big point there. So when we look at, a lot of when it comes to the digital companies that have done this first and raised a lot of the money, the big heavy hitters have been Hinge and Sword, and you've got some other ones like Kaya and Amada and these other ones, and they do provide most of the outcomes that we see for these specific programs. And the outcomes have shown that even digital only can save significant dollars. It can improve employee productivity. It can reduce missed time from work, which those things a lot of times can go hand in hand. So we see benefits with them. As you already alluded to, one of the biggest problems is the utilization rate is around 2%. And a big driver of that is people still want an in-person component to it. That a lot of them are looking for hybrid or having that option, even if it's just an eval, 1 or 2 visits. Yeah. And so that's a lot of our focus, is that, all right, we can provide a lot of that digital footprint, the digital services, but physical therapy practices already have the brick and mortars in place. They have the staff, they have the people. So why don't we marry those two together? That then gives patients the best of both worlds. So that's something that still needs more vetting out in terms of what are the outcomes of digital only versus a hybrid care approach. What is the right hybrid? I would venture to guess that you're never going to find a one-size-fits-all, which is the case for research in general, right? Some people may just want the eval in person. Some people, for an acute case versus a chronic, you could have the same individual where, I'm familiar, I've sprained my ankle before, I don't need to go in person. Or, I'm really worried about this neck pain, I haven't had this before, I want to go see someone now in person. So you want to have that flexibility.
Yeah. Well, I like the business model too of not needing to like the upfront capital. We're just going to build clinics everywhere, like we're just going to go and empower these clinicians that are already out there and just give them the tools to do it. And that's essentially what you're doing, right? Like somebody signs up with Second Door Health and now they're empowered to go to those Home Depots or those, regional employers and say, we've got the tech stack to do it and you can use our clinic, right?
Yeah, and there's so many of these regional employers that need assistance. I mean, we see a lot of the a big marker of where we see a lot of employers switching to self-insured is around the 200 mark. And it's not that that's a magic number, but that's where you start to see a big jump.
It makes more financial sense for them to do it at that point.
Exactly. And there are other models where you can have a bunch of smaller employers kind of pool their resources together so they minimize their risk, but they also share kind of in the risk. It's just a small reward, but it's still better than them going with an actual private insurer payer. So there's a lot out there. And where we see also a lot of success, for example, is in municipalities where you have local town halls and you have fire departments and police departments where they're self-insured. And you can see individual practices where it might just be a single brick and mortar mom and pop type clinic that says, hey, yeah, I can service a local municipality, and they set up contracts with them. So you don't have to go to these big giant players. And it's hard to go to them anyways because you don't have the regional density to service all their employees. So a lot of what we want to start out with is just hitting those regional employers, hitting those ones that you can provide value to, and it gives you a constant stream of employees. You don't have the red tape and all the administrative burden that comes. That's a big driver. We talk about struggles in physical therapy and staffing and people really burning out.
Yeah.
Administrative burden is a big part of that. Well, if I can take that all out and I just need basic documentation essentially to cover myself. I don't have to worry about prior authorization and all this nonsense and visit limits. I'm just getting the person better. That really improves the quality of work as well.
Yeah. Yeah. So then segue here, tell me how clinical content fits into that picture. Because obviously when we think of like going direct to employer or just providing services in general, a lot of people are thinking like the treatment where you're doing something, you're giving the person a prescription of exercises or home program. Like how does clinical content kind of inform that, but then also act as its own standalone piece of that puzzle?
Sure. A lot of it is providing options for meeting the patient where they are. Because you're going to have, as I mentioned earlier, patients have varying degrees of need of what knowledge they might already have. Some individuals for some conditions may just basically need validation. I have examples of, people in my neighborhood, they know I'm a physical therapist, and there's some times where they'll just come to me and say, hey, look, I tweaked my back or I felt this pop. And it can just very quickly be a 5-minute conversation of validating, yep, you're going to be fine. Here's some activity you can continue to do. And they do great. They recover. No issue at all. They don't need to go through a 12-visit plan of care and all this prevention and assessment and all this stuff. There are some cases where someone might have a larger concern and there's more fear-avoidant behavior and worry involved. Okay, well, let's go ahead and do a bout of care. Some of them are going to digest material, and we provide online material where it might be email campaigns where, hey, you get this regular campaign of clinical content. And you want to give it in different ways that they can digest it. Some want video, some want infographics, some want a full long-form blog where they want to dive into it. And then there can be self-paced programs. So one of the things we're working on is building a self-paced low back pain program where someone can just sign up for it. That could be something they do alongside their treatment so they have more resources available. It could be something you give someone during a wait list. So, hey, I've got 2 weeks till I can get them in for an eval. Well, here's a low back pain program you can do in the meantime to self-treat. Or for some, it's just, hey, just tell me what I need to do and I'll do it. And, okay, cool, here's a full self-service program. So there's a lot of ways to go about content. It's just meeting the patient where they are and what they're going to use.
Yeah. I was about to ask, like, what's the breakdown? But it seems like if you're covering everything, I'm a big fan of, like, you create something one time and then you use it as many, like, on different platforms, different formats. So I'm assuming this is the same type of thing. We're going to do, like, short videos maybe or segments or, like, long form. I'm assuming, since everybody's different, there's no, like, definitive research on there. But is there any type of content that this type of content, like clinical education content, that gets either more engagement or better, like can be correlated in some way to clinical outcomes, or is it kind of like, well, it kind of depends on the patient?
Yeah, a lot of it really does depend on what the outcome is that you want, right? We do know there needs to be frequent touch points, and that it's going to be something that resonates with the patient and what information they want, that there's actual takeaways. A lot of times, this is something that I had to learn a lot of, is that a lot of my education in the past had been to residents and physical therapists that have a different level of healthcare understanding of health knowledge. And there's also some information you can give them where it's like, oh, cool, fun fact, I wanted to know that. Where a lot of times the patient is just, tell me what I need to do.
Yeah.
What is going to change my pain or help me do it? It needs to be a lot more action oriented. So that has been a bigger focus as well. When I think about the education you give someone, it can be helpful to understand the why, but a lot of it needs to be action driven, and then it needs to drive results.
Yeah, cool deal. And I guess, so what's the vision for, I guess, your role in creating all this content for Second Door Health? Is it one of those, like, you're going to white label this through the provider organizations, or is it one of those, like, we're just going to have this big bank? Like, what are y'all still teasing around with how that's going to work? Or
yeah, kind of a combination of that. So the idea is white label of just, I can create, and here you can use this directly. You can make modifications to it as you see fit. You can give me things you have, and I'll help you modify it and curate it. And there would be a big bank of information. So right now there's various campaigns that can be used. So here it is for pain, here it is for exercise, which is a big focus, diet, nutrition, here's running, here's osteoarthritis. It's what does the patient want? One of the big areas of clinical content, and this is an area that can be also tricky when you're not working within just one organization, like PT Solutions, I knew the culture very well. I was in charge of a lot of the educational content. We'd have in-house education that we could make sure we're all speaking the same language. While ideally, everyone treats to the most up-to-date evidence, there's a lot of variability. And we have different patients. We have different types of providers with different knowledge. So sometimes if I create content, and I've talked with different clients of ours and those that are involved in education, going, hey, I love this. We might not all be doing this right now. What you don't want to do is to send a patient a piece of information that contradicts what they're going to hear from their clinician in the clinic.
Yeah.
So
Or even sets up different expectations, like this is the standard of care and yada, 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 and they're going to a clinic that does something totally different.
Exactly. So you may have seen, I talk a lot about, and I've written about, and podcasts on not fearing rounding your back, or not having a big emphasis on posture, and a lot of movement optimization. And so if I write a big article or send a video or something to a patient, and then they go in the clinic and someone talks about, you've got to maintain a neutral spine, you got to bring your shoulders back, and really don't make sure you round your back, you're going to hurt yourself. Okay, who's the patient supposed to believe there? So there is this balance of, you want to have contextual information that's meaningful to someone. If it's too generic, they're not going to use it. And you want it to be actionable, but you also want to make sure it's a consistent message. So you have to have enough information, and you got to customize it enough that it's consistent, whoever you're using it with.
Yeah. Well, and I imagine some of that too is, it's just interesting to get into the variability of practice. You get two clinicians treating the same exact, even sometimes the same exact patient, they're getting completely different treatments. So it's difficult. You can't standardize anything. So when it comes to creating this content and putting it together, are y'all using any, or have you explored using things like, I don't know, artificial intelligence is a big thing, right? Like something that, not that it's just going to generate it all for you, but that you can put the inputs in. Maybe it's some research articles, or maybe it's some protocol or something like that, and it kicks out some content that you can use, or like, what have y'all played around with in that regard?
Yeah, a lot of where I'll use generative AI is for condensing the content. So a lot of my content started with long form blog, where I would create a large amount of content on a given topic, heavily researched, but written in a way, try to aim for like more of an 8th grade reading level, just something that a lot of people can digest in that 6th to 8th grade range. And from there, I will use AI to say, okay, I want now an email prompt. that I can now boil this down that can be put into an email, and give me bulleted summaries that I can immediately put into an infographic, and now condense this down into a video script or something like that. So it's finding ways to take that, like you said, take the one big piece of information, and now let's turn this into 4, 5, 6 more digestible pieces of information. And that's where AI has been beneficial in, that is it can be a lot quicker, that I could have these prompts, just copy paste the prompt, put the whole article in. Okay, now I've got my 4 pieces of smaller content that I can much more easily use. So I don't use it to make the original long form, but I will use it to make those modifications, or to say, hey, take this long form and now make it into 6th grade reading level and correct for grammar and things like that. So it's modifying what has already been created.
I think, I'm glad you said that. I think that's a big point. There's a lot of, I don't know if you've done this, but I've messed around with, ChatGPT or something like that. And I'm like, okay, give me just an article on treating like shoulder pain or something like that, and with 5 citations. And like 4 out of those 5 articles are like totally made up. It's like,
yes,
it knows that Raffi is published on this, that, and the other, and he's published for these journals. So maybe there's an article that has this exact title that just happens to fit the prompt. And there a lot of people that I've been talking to are like, oh yeah, just have ChatGPT create me an article, and I'm like, well, are you verifying the sources or the information? Because there's a lot of that coming out now where it's like AI has generated the entire thing, and it's basically not based on reality, right?
Yeah, I'll ask and I'll say, I'll put in ChatGPT to give me the DOIs of the citations.
Yeah.
And sometimes the DOIs don't pull up anything. They pull up an article that's completely different than what I wanted. So, and also just knowing what year it's pulling from, that, when I was messing around with this, it was just 2021 was as high as it would pull from. So you're not even getting more recent evidence. Not that anything 2021 or earlier is bad per se, but I want to capture the most recent. So yeah, I don't use it to generate any original content. It's just to modify what I've already made.
Cool deal. Well, I'm going to ask you the question that I always close with. So if there's like 1 or 2, we've talked about a lot. We've talked about direct to employers and direct payers, and also clinical content. So maybe give me like one main point that you'd want like a clinician to walk away with for the direct to or the direct payer piece or the direct to consumer piece, and then about clinical content. Maybe one of each. What's one thing you would want people to walk away with from the episode?
Yeah, I think for the direct pay piece is to, really, if it's something you haven't explored yet, to just get a better understanding of it, because direct pay is something that really helps diversify your revenue for a practice. It helps get rid of a lot of the burdens. When we look at the model of physical therapy, we know reimbursement continues to decline over and over, or at least it's, even if it's not declining. Pressure. Right. It's at least it's not keeping up with inflation, rising costs, and health everything. So it's still a net negative in the equation. We got to find something else, and that's where direct pay and going directly to the consumer, directly to the employer, can really provide you a lot more leverage, because you're just not going to hold leverage over the insurance companies ever. So if we can get more individuals going this direct pay route and talking to employers, it's a slog. It's a long time to get an employer contract, but there's a lot of potential benefit to it. So I would just leave you with, look more into it. Obviously, we'd love to talk to you at Second Door, but even outside of that, just get a better understanding of direct to employer, because it is a great option for most practices that are out there. On the clinical content side, I would say that the big takeaway is to really diversify your content offerings to help engage patients, because a lot of patients, they do want the capability to do things on their own. We need to move more to this hybrid model, that it's not that you need to come to the clinic, or, people don't do their HEPs, so clearly HEPs don't work. Well, how effective was it? Are you giving them a sheet of paper with 2 to 3 exercises that are low intensity, expecting that to work? Or are you teaching them how to program? Are you teaching them how to measure intensity and volume? Are you giving them content they really want? Are you talking about diet? Are you talking about sleep with actionable takeaways, not just, get more sleep or eat more protein? Well, let's figure out how to do those things. So I think historically, a lot of physical therapy content has been way too surface level and too generic, where we need to get more content and be a little bit more prescriptive.
Yeah. No, those are great points. Where can people learn more about you, about your work, connect with Second Door Health? Are you still running the podcast?
So I'm not doing the podcast right now. It's something that I might be doing a little bit more later. I mean, you can still find more. I still write content on Medium, and I'll post it on LinkedIn. So that's what I'm most active on, is LinkedIn, and then Medium, every now and then on Instagram. Second Door, you can learn more about us on the site, seconddoor.com, or Second Door Health, I'm sorry. And you can also find us on LinkedIn as well. You can reach out to any of us, Scott Hebert or Ryan Kleps, our co-founders. Happy to talk to you guys as well. But yeah, check it out. Check both out. LinkedIn, great place to connect with us.
Cool deal. And we'll link to all that in the show notes. So thanks so much, man. Have a good one.
Yeah, appreciate it. Thank you.